Welcome to the Explainer. Today we're tackling seizure semiology. It sounds kind of complex, right? But really it's just the fancy term for studying the signs and symptoms of seizures. Think of this as your survival guide, your toolkit for when you're on call and you get that page.
All right, picture this. You grab the next chart and the chief complaint is just, I had a spell. That's it. So vague, right? It could be absolutely anything. And it's totally on you to crack the case. This is exactly why you need a solid game plan. A systematic approach is everything here.
So, now what is the question, for sure. But don't worry, we've got you. In this explainer, we're going to walk you through a super practical framework. The goal? To take that super vague complaint and turn it into a confident diagnosis, using the clues you can pick up right there in your clinic.
Okay, first things first, let's get on the same page with the official definition of epilepsy. A lot of people think it's just, having 2 or more seizures. But here's the kicker, and this is super important. You can actually diagnose it after just 1 unprovoked seizure. If, and it's a big if there's a high chance it's going to happen again. That's a really key clinical point to remember.
All right, before we get into all the fancy classifications and tests, there is one golden rule for your outpatient history. Seriously, this one thing is going to give you more juicy, useful info than pretty much anything else you do.
And here it is. The patient, they often have zero memory of the event, total amnesia, so they can't tell you what happened. This means your best informant isn't the patient at all. It's the witness, a spouse, a friend, even a bystander. That's where your detective work really starts. You've got to get that detailed story from someone who actually saw it.
Okay, so you've got your witness. Now you need a map to figure out where to go with all the clues you're gathering. And that map is the ILA 2017 classification. It's the modern framework, and it gives you a really logical way to think through any seizure.
And check this out. This is the process in a nutshell. It's a step-by-step thing. You don't just guess a seizure type. Nope, you work through it. Step 1. Where did it kick off? Just one spot? Focal? Or the whole brain at once? Generalized. Step 2. What was their awareness like? Were they aware or was it impaired? And finally, Step 3. What did it actually look like? Were there motor signs, non-motor signs? See? It's a logical flow.
All right, let's put this framework to the test. We're going to start with focal seizures, the ones that fire off from one specific spot in the brain. And this, my friends, is where neurology gets super cool. Because where the seizure starts, that location, gives you a ton of specific clues about what to look for.
Now, this is an absolutely classic comparison you have to know. On one side, we've got temporal lobe seizures, by far the most common type in adults. Think of classic auras, that weird rising feeling from the stomach, a sudden blast of déjà vu or fear, followed by those automatic behaviors like chewing or lip smacking. Now, compare that to frontal lobe seizures. These can look so bizarre. We're talking violent bicycling movements, pelvic thrusting. They're often super short, happen during sleep, and then, poof, the person is right back to normal. Totally different vibe.
And because those frontal lobe seizures can be so weird and easy to misdiagnose, here's a killer mnemonic to lock it in your brain. The 3 Ps. First, P for paroxysmal. They have a really sudden on and off switch. Second, P for posturing, those bizarre complex movements we talked about. And third, P for postictal period, which is basically non-existent. They recover crazy fast.
Okay, so we've covered focal seizures. Now let's switch gears and talk about what happens when it looks like the whole brain lights up at once. These are your generalized seizures. And, yep, you guessed it, they've got their own special set of clues we need to look for.
Okay, let's talk about a classic sign, the tongue bite. Everyone asks about it, right? But here's where being a sharp clinician comes in. It's not just if they bit their tongue, it's where. The location is everything, and it can be a massive clue. And this right here is a clinical pearl you should absolutely file away. A bite on the side of the tongue, the lateral aspect, that is highly specific for a generalized tonic-clonic seizure. But a little bite on the tip? Not so much. That's way less specific. You can see that with fainting or even in a non-epileptic event. Some of the most common generalized syndromes get missed all the time. Why? Because patients don't think their symptoms are a big deal, so they just don't mention them. You have to be the one to ask. So for absent seizures, you've got to ask, hey, do you ever have these brief staring spells where you just lose time? And for JME, which is super common, you have to ask specifically, what about in the morning? Do you ever get kind of clumsy or have these little jerks in your arms, especially if you didn't get much sleep? All right, so an absolutely crucial part of this whole process is remembering that not every spell is a seizure. A huge part of being a good neurology detective is ruling out the imposters. So let's talk about the common lookalikes and how to tell them apart.
This table is basically your field guide for this. Let's hit the highlights. First, look at the eyes. In a true epileptic seizure, the eyes are almost always open. But in a psychogenic non-epileptic seizure, or PNES, they're often squeezed shut. Big difference. Next up, duration. Most real seizures are pretty short, usually under 3 minutes. PNES can go on, sometimes way longer. And finally, what happens after? That postictal confusion is a huge flag for a seizure. With syncope or fainting, they usually pop right back to normal.
Okay, here's another tricky one. Migraine with aura versus a seizure aura. They can feel similar, but the key is the clock. It's all about timing. A seizure aura is fast. It spreads and evolves over just a few seconds. A migraine aura, on the other hand, is a slow march. It builds gradually over 5, 10, 15 minutes. Seconds versus minutes, that's the key differentiator.
Okay, so you've done the hard work. You got a great history, you've used the framework to classify the event, and you've thought about the mimics. So what do you actually do next? Time to put together our action plan.
Believe it or not, your physical exam can give you some amazing objective proof. 2 high-yield things to look for. First, check the tongue really well. Look for old scars on the sides from past bites. And second, check the shoulders. A posterior shoulder dislocation is super rare in general, but it's a classic, almost pathognomonic sign of a past tonic-clonic seizure.
All right, let's talk about the EEG. It's our #1 test, right? But there's a huge pitfall you have to know about. This is the chance that a single routine EEG will actually find something wrong in a person who definitely has epilepsy. It's kind of shockingly low, isn't it?
And that brings us to maybe the single most important clinical pearl in this entire explainer. A normal EEG does not rule out epilepsy. I'm going to say that again because it's so important. A normal EEG does not rule out epilepsy. Never ever let a clean EEG report make you doubt a really compelling clinical story.
And that's really the bottom line, isn't it? It all comes back to this. Your tests, your EEG, they're just tools. They don't make the diagnosis. You do. The story, the semiology, the clues you piece together from the patient, and just as importantly, from their witness, that is everything. So at the end of the day, the real question isn't just about what the tests say, it's about whether you've truly listened to the story the seizure itself is telling.